Oh, kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit. This is an auspicious day because this is the day that primary care will start managing patients with COVID. We're going to be introduced to Whānau HQ, COVID care for the community. And our main speaker is going to be Christine McIntosh from NRHCC, who's going to walk you through from beginning to end the process that we'll be going through. We will have a talk from Lara Hopley and Dr. Rawiri Jansen later on in the evening. So over to you, Christine.
Kia ora, thanks, Bruce. Welcome everybody again to second webinar within 1 week. So for all of you who joined us last Thursday, we had an overview really of the COVID Care in the Community program, and really this is a follow-up to that to take you through step by step how to do that COVID care in the community. So I'll just start sharing some slides just so that we can start through there, and I really encourage you to add the questions and the queries there, because we'll have time at the end. So really just tonight, really want to give a brief overview of the program, then talk a little bit about practice setup, talk about the Ministry of Health phasing of Omicron response, and then we're going to talk in a lot more detail about the COVID clinical care module, and you might have heard this called BCMS. We have Lara Hopley on here, who is going to help us with the tour of clinical care module as you would see it as you go in from your practice management system. And we're going to go into quite a bit of detail that we're going to talk through the health pathway, which has been refreshed from what you previously would have seen for the health pathway, and that's specifically for the Omicron response. And then we're going to really just talk it through from a care person journey. We've got Rawiri, who's going to talk more about the Māori Coordination Hub, and also we'll talk about what the Pacific Coordination Hub roles are here. We'll briefly talk about what the role of hospital in the home is, and then we'll go through some questions and answers. So really keen for you to put your questions in the question, and we'll get to those. Okay, so just really thinking about how to set up in the practice, because apparently there have been quite a few questions from that the PHs are telling us, and what we're expecting is for primary care to start responding to those positive test results that are coming in the inbox. So up through the Delta response, really the message was to primary care is certainly you could respond to that. You could ring your patient and explain to them that they had COVID, but that you were expecting that contact tracing would carry on, and that their care would be coming under either the Māori or Pacific Coordination Hubs or under Whakarangaro Healthline to do that care of the person in the community, and also of their household bubble, which included quite a lot of symptom checking questions and so forth, and managing isolation periods and so forth. It has been quite a labour intensive process, and I would have to say that going into the Omicron response, we understand that needs to be quite different, and so I'll talk through what the differences are for that. So essentially from a practice point of view, it's about checking for those results and thinking about who might be doing that on behalf of the practice and doing that at regular intervals. So if a practice is quite prepared to do that COVID care, and I just would add that we really do have to think about how this happens across the entire system as those numbers swell. Then you will know that a COVID clinical care module record has been created when you get a COVID community case inform. So it's a bit of a mouthful. And this is what it looks like. So you will have seen these come into the inbox. If you've had some positive cases come through your practice. So this is generated at the point in time when that COVID clinical care module record is created. So that's really your cue that one is there. For people who might have been checking for that today, we had to do a workaround in processes this week to achieve getting that clinical care module record completed, and there were some initial delays in getting that done this morning. So if you went looking for it, it wasn't quite there yet, but we're on to it and you'll find them going ahead. You won't necessarily find them going backwards a day or so, because contact tracing takes a day or so to go through the processes, and therefore the clinical care does not start until those processes have gone through. So there's a real advantage to primary care getting on board early and letting their patients know that they have COVID, because you're able to start that clinical care a lot earlier than otherwise would happen in the sequence of events. In the practice, it'll be important to think about who will check these results. If you're not a GP that works every day, but of course your cases might have COVID that need to be checked on a daily basis, it's really important to think who will be doing that. It's also important to think about whether you're a practice who's prepared to work on looking at those COVID cases 7 days a week, which is probably relatively unusual, or if you're a practice who are going to be able to do that within normal business hours or normal days of the week. What I would say is that we will have clinical cover in place for the weekends and public holidays within normal business hours, who will be able to check those results and act upon them going forward on behalf of primary care. And what we would really encourage then is for primary care to pick up those cases during the business week. And I'll show you how to do that within the system. I think it's a really good idea for practices to think about what low volume care looks like versus high volume. So initially you might see a trickle of cases coming through, but if we're anything like what happened in New South Wales, then there will be quite a high volume of cases coming through. But it's also really important to set expectations about care. And a lot of what I want to talk about tonight is actually, this is not Delta, this is Omicron. And what we're really seeing is that there are a lot of people who have Omicron who are not particularly unwell and are managing quite well in their homes. And making sure that we are not putting undue clinical care into pretty well people who need to isolate at home with their Omicron, and that we're focusing care around those people who are at much higher risk or more moderately unwell with their COVID. Okay, just talking a little bit about the Omicron in the community and what this means through the phasing. At the moment, we're somewhere between phase 1 and phase 2. The ministry will tell you we're in phase 1, but we're somewhere between phase 1 and phase 2 as far as thinking about our clinical care. What you'll notice is there's some differences, and I'm just going to really summarize the clinical differences here. Still in phase 2, we expect that a positive PCR test will be what makes a case positive in the system. But what we can see is some changes that might occur from phase 1, which we are currently into phase 2, is that the patients will start to get direct to them text messages that tell them that they're positive, and with a link to initiate some self-serve components of that. And the contact tracing will continue in phase 2. So there are some key differences here, and that is in phase 1, we have the 14 days of isolation and 10 days, which is sequential to the cases 14 days of isolation that contacts then need to isolate for a further 10 days. And this changes in phase 2. And this is really quite important because this has been quite an arduous thing for families and households who've had to isolate. And it changes to a 10 and 7 days. And so that will make a difference. And at the moment, we just have to straddle the two. What I would say is that we need to take the approach again of those household contacts about doing a lower touch care than what we have done previously, and focusing our case contacts predominantly on making sure that we're looking after the higher risk. So I'm just going to switch to the health pathways now and just walk you through the health pathways. So I'll just do a little bit of a switch. Okay, so you should be able to see the health pathway now in front of you. So this is the COVID case management in adults. This has been updated. As you can see, it's very fresh, the 9th of February. We haven't yet updated the case management in children pathway. And I just want to acknowledge Helen Liley, who is the clinical editor for Health Pathways in Auckland, who has been put an immense amount of work into getting this ready. So this has a lot of information here, and I hope that most people in Auckland are very familiar with Auckland Regional Health Pathways, that you can find a lot of information under COVID health pathways here. There's just a brief introduction about what's new. Now, I think that there was a question there about what do you do for women who are pregnant, who have COVID. There is a health pathway for that, and that outlines very specifically the care required for women who are pregnant, and who to call, when to call them, what considerations you need to have in mind. Just really important to obviously let the LMC know that that woman has COVID, asking her to contact her LMC or doing that yourself. It's really important that as of today, yes, primary care, wherever possible, should act upon a positive result, and really encouraging you to become part of the whānau HQ community of care for patients in the community with COVID. And that way that we can share the load across the system. And I recognise that it is a load, and that you are already working very, very hard, and making sure that we're able to share it across the system and actually provide that to people in the community with COVID. So, and then it basically just talks us through, again, what we've been talking about, assigning a staff member, and making sure that you've got COVID clinical care record available. And Lara's going to take us through how to do that. Just how you find it, you open the patient record and then you use the health link tab. Lara will show us how to do that. Now, really important to note for Māori and Pacifica patients that we've had a very specific Māori and Pacific response to COVID through the Delta outbreak in Auckland, and we have Māori and Pacifica hubs to particularly meet the needs of Māori and Pacifica communities. And when Māori and Pacific hubs contact their patients, they may offer an alternative Māori or Pacifica provider to your patient, and if that's what they choose, then they may do the ongoing care. But that's not going to be all patients. But to ensure that there's no delay, it's really important that you don't delay picking up your Māori and Pacifica patients and informing them that they have COVID and helping them immediately with whatever needs they have. And that's and where you will know whether the Māori and Pacifica hubs have actually taken up the care of that patient is you will find that information in the individual assessment and plan guide. And so Lara will show you where to find that as we go through the COVID clinical care module. So for all patients, if no assessment has been completed, and you can see that when you go into the COVID clinical care module, you're able to accept the care. So this is how you advise, and it just takes you through the instructions about how to do this. You create a task on there and let the hub know. And we'll let you know when we know, and we'll complete that task. If you're not able to accept the care, so if there's some reason why your practice is not able to accept the care, we'd be really keen to know that, please. So that's a really important thing. Say, let us know that you're opting out of looking after that patient, and we'll find an alternative provider to look after that patient. If an initial assessment has been completed, you can check the tasks and so forth, and if you are able to accept the care. So what you might find is the Māori or Pacifica hubs have said, we've done an initial assessment, but please could the GP now take over the care of this patient, and they will have set a task within those tasks, and it's really helpful, please, if you can go and look at those tasks and accept it if that is possible to do in your practice. So there's just a whole lot of little processes there. Once you get used to the task thing, it kind of makes sense. It's just like you do tasks normally with your own practice management system. Then again, you've got your background on COVID case management. And then we go to the case management. So complete the assignment to self-care or monitored care. and determined using the acuity score. So we've talked before in Auckland about using the acuity score. It's now written into the national pathway, and that really helps us to decide what level of care people need. This one takes you through all the things that you need to do when you're thinking about whether or not this person needs to have ongoing close management within the practice, or whether this person can have an initial assessment, and then if you're happy that they're themselves and the whānau are managing well, then you can let them know how to contact you if there's any concerns, but otherwise you can inform them of when the testing needs to be, and then ask them to call you if there's any problems, basically. So it just takes you through that. It takes you through the things that may or may not cause complications. And then you enter the acuity rating. So the acuity rating is one that you may have seen before. It's been translated because people found it somewhat confusing, all the different age ranges for all the different ethnicities. And now it's a really nice, clear chart. So you can see the COVID symptoms there, what's asymptomatic, mild, mild to moderate, moderate. You see the comorbidities down here, and you can go, are they mild or asymptomatic, or are they mild to moderate symptoms, or do they have severe symptoms, in which case you'll be admitting them to hospital. So this just helps you to determine which acuity is. The further down you go, the more concerned you are about the person. And we are asking primary care particularly to focus on the 5s and 6s, because these are the people who are mild to moderately, more moderately unwell, or have been recently in hospital, or have some other conditions that would want you to look after them and keep an eye on them a bit more closely. Whereas the ones who are asymptomatic and mild, and actually a lot of people who have Omicron at the moment are asymptomatic or mild, because we've got obviously a highly vaccinated population, and that vaccination is really paying off now, because even though it doesn't stop people getting completely stop people getting Omicron, what they're experiencing is a more mild illness, which is really great. So we really have to focus our care around those that have significant comorbidities or are unvaccinated and are more likely to get more severely unwell. So that's just the acuity score chart, and we'll show you in the COVID clinical care module where to put that. And we're suggesting that people in the acuity score 1 to 4 really enter into that self-care. So you've done the initial assessment, you know that they're able to call you if they need to, and really you can let them know when their contacts need testing, and set them free, basically. Not literally, they do have to isolate, but you don't need to do that calling every day, and that's what's distinctively different to the Delta response. Okay, pregnancy and postnatal pathway. Ask about anyone else in the households who's not already under the COVID self-monitoring or monitored care. Just asking about whether there's anybody who's symptomatic, concerning, or anybody who'd be particularly high risk. And this is the difference between Delta, where you have to know everything about everybody in the household in a lot of detail, and you need to do a symptom review every day. We're not asking that anymore. This is really about troubleshooting anything that you need to know about within that household. If that patient is a patient of your practice, then obviously if they're symptomatic, organise the testing and follow through with that. If that patient in the household who is symptomatic is not your patient, then please feel free to give some advice, but also advise them to contact their own GP. It's the best that we can do in trying to manage a bubble. Ideally, it's all managed by one practice and it's a bit more straightforward, but obviously if that's not practical or people want their own GP, you do have to separate it out. And just some more things here about administration support and so forth. If you need to create a CCM record for them, so that might be somebody who's symptomatic as a household contact who may not have a record yet, then you can request that support, okay? And this is how you do it within the case in the household. Okay, I'm just going to collapse that. Okay, the clinical review, again, just taking you through it. Okay, asking about the questions, manage symptoms, just recognising that we have the COVID-19 pharmacy service, and so there are over 150 pharmacies throughout the Auckland area who have signed up to provide COVID-related medicine support for families, and they do not have to go through as a GP to get some basic medications prescribed for their COVID support, so paracetamol for children, rehydration fluids, paracetamol for adults, and so forth. They are able to do that, and they are funded to do that and deliver it to the house, which is really, really helpful. And those pharmacies, there's a list here of them, but they'll also be advertised on Health Point, and it would be useful to point your patients towards those to try and unburden the system a bit, so getting them to ring their pharmacy directly for those medicines rather than requesting scripts. There we are, pharmacy referral. Okay, thinking also about those people who should have budesonide prescribed for them, and you've got the information there. The pulse oximeter. So what's different to Delta is that with Omicron and through the learning from people who had pulse oximetry through the Delta outbreak, our clinical governance group have determined that we will send pulse oximeters out to the acuity 5s and 6s. And so, so these are the people who are more moderately unwell or have a much higher risk of severe outcomes to their COVID. And that will be delivered by one link. So you're able to set a task and actually have that, and that will set the one link who will do the delivery to the home of the pulse oximeter. It will also come with a book on the whānau HQ guide as well, so the hard copy of the whānau HQ guide for families. Comorbidities, substance use, it tells you what to do here. Investigations, you shouldn't really need to do much in the way of investigations. What to do about unwell household members, and any other concerns that you might have. There's an operational line that you can call at whānau HQ if you have any concerns, and the appropriateness of home-based care, but that also might be other concerns. So if they have home help support that is not possible to continue while they have COVID and isolating at home, so any of those other issues, you can ring the ops line. Okay, Manaaki and welfare needs. Sorry, I've skipped over information for patients and their caregivers. There's a lot of information here, okay, and really important that you read through and see what's available. The Manaaki and welfare needs. So there is a way of requesting the welfare options, and we'll show you where that is in the CCM. Okay, I'm just aware of time, so I'm just going to keep moving. Discharge from clinical care and release from isolation. Lara can take us through that as well. Follow up after discharge from regular review, just recommending the vaccination still post infection. And for those people who are admitted to hospital for more than just an ED stay, you're able to do that 6-week follow-up. Care after hospital discharge and death in the community. Now, it's really important here in the request section that you know who to call. So if you're wanting some advice, you can get some advice, and this goes to the infectious diseases consultants in the Auckland area according to your DHB. But if you're needing to admit somebody to the hospital, you ring this line here. Okay, so the clinicians are really happy to give advice, and in our webinar that we'll do next Thursday, we'll have some of those clinicians available to answer some of the commonly asked questions that GPs have about their patients with COVID. Okay, I'm going to stop share now, and I'm going to ask Lara to share, and she's going to show you what it looks like to start to go through. Okay. Thanks, Lara. So when you're looking at it, you're going to look for a positive result in your inbox, and then you're going to open your CCCM record. Yep,
your patient record. So click on the health link form.
Yep.
So again, just to make clear, I was already in patient context over here within the patient context, within the patient context.
Yes, so you've got to have your patient up on the pallets to be able to do that, and that's just pausing there. So previously, for other people who might have used, they might have seen as the BCMS. It's now COVID clinical care module there. So you'll find it there along with all those other things that you're used to finding in the HealthLink referrals. Thanks, Lara.
One of the first tricks for young players, what I would suggest is to make that big screen so that you get the full advantage of your screen that you've got over there. Sorry, Christine, back to you.
No, brilliant. So, yep, so these are good tips. So this was formatted for use on tablets. It's lovely and big screen, it's great. And so when you go in there, the first thing you want to do is you want to look and see, well, you can do a timeline. Yep, you can see exactly what's happened. So you can do it the vital timeline, and that gives you a summary of everything that's happened. So if somebody's already gone in there and done an initial assessment, if you look at that note timeline, you'll find it. If nobody's done anything, it's empty, essentially, your first thing you'll do is you're going to go in there and do an initial assessment for your patient. So what I suggest you do is that you might actually be able to go in there and start this before you even ring your patient. You might be able to, because you know their medical history. Unfortunately, at this stage, it doesn't draw it across from your practice management system, but you just need to really put some basic information in there. The purpose of putting some basic information in there is that this is a shared record across the system, so that if at the weekend your patient needs to have a clinical review and it's not something that your practice is able to do, then you'll be able to request that from the NRHCC Whānau HQ hub. And having this information in here is enabling that person who's going to do their clinical call to know a bit more about your person.
We'll just point out the underlying conditions from the National Contact and Tracing System. This does get, we are going to the self-serve where the person themselves will get a text and will be able to fill in their own underlying conditions and their own bits and pieces. And so if that happens, it will come into here. You'll be able to see what it is. There's not an enormous amount here. You can select all and save, and it will save on and answer the questions there as well.
Yeah, so I love having Lara on because she knows exactly what's happening. So this is constantly, well, not constantly, it has a number of updates that are occurring to the systems over time. And so there is an update happening tonight that will add some additional functionality there, but it essentially will function the same for you. Okay, and there are a number of pages here. I think this is a trick for new players. So just realizing down the bottom right-hand corner there that there are a number of pages to this initial assessment. So you keep scrolling through. Okay, and there's some things to answer there. Just thinking actually really important to talk about people who do have a dependency on alcohol or drugs is that isolation can have some particular challenges for them, and it's really important to talk to people about how they're going to overcome some of those challenges and get support either for contactless delivery of what they need or talking to the community alcohol and drug service about supporting them with their needs during that time. It has particularly been important for households who've needed to isolate during the Delta outbreak for quite prolonged periods of time. Okay, and the next page.
This is not particularly useful at the moment, and I'm quite happy if you don't fill in any of this. This is very much aimed at the border. Same thing, it's a little bit sad we haven't been able to give you the COVID immunization register information, but it's not actually physically there in the National Contact and Tracing System, it's only a view. So we're working very hard to get an API, so an application programming interface so that we can pull it. So again, probably a week or two away.
Yep, so that's coming. Okay, and this is where you raise a welfare assistance to MSD, okay?
So I do apologize, Christine. This is a real trick for young players and you really must do this. This first one doesn't go back to the National Contact and Tracing System. The regular health check does.
Oh, okay,
So
important.
Think about, yeah, real trick for young players. I do apologize. So you can think about it that you can write them here, but that won't go back to National Contact and Tracing System. So we'll talk about it again when we get to the regular health check.
Okay, and next page. Okay.
Yeah.
So this is an important page because if the Māori Pacifica providers are providing the care, then they're going to note it in this space here. Okay, so this is really important, and you'll see it in that summary page that we also showed, Lara showed at the beginning. Okay, great. So, and when you've finished, you need to click that green complete button. If you, yep, brilliant.
And then it shows it quite nicely.
Okay. Then the regular health check. So when you're doing an initial assessment, you're doing the background information and then you're going through the symptoms. And Lara, you can run through that. Would that be all right? Yep.
Yeah, absolutely. So none of these, we've made very few fields mandatory, almost none. What we have aimed at with the help of Helen and Christine is aimed at some red flag questions. So that was one of the questions, what are the important ones? The shortness of breath does go on and ask you a couple more and actually asks for an assessment as well. And that would be one of the self-reporting questions that we build in as well. Does have a little bit of an advice, a little bit of a script here for people to take note of how the person is talking to you rather than just doing going through a checklist and being cognitively channeled into one thing. It's actually more of a conversation with the person and filling in the answers as you hear the answers. Again, with the red flag questions, a bit of an assessment of the hydration, which is difficult in adults, but well worth doing and just more as a prompt so that you can see how things are going over there. The how are you feeling today, same, better, worse, the shortness of breath, and the one that we haven't put in here, how are you doing yesterday? What could you do yesterday that you can't do today? Or showing that deterioration or shown to be quite good negative predictive values. If they are all fine, it's quite negatively predictive that they won't need hospitalization.
And I think what you'll find as you start to work through the pathway, the first few times you do it, you need to work through the whole pathway and all through this, but then you'll start to hone in on the questions that you really need to ask and how are you today compared to yesterday, same, better or worse. And those are the ones that you really start to hone in on.
It's at this point, having done the initial assessment and those symptoms, that you can go and look at that acuity rating that Christine spoke about. And so you notice that it's come in as blank so that we don't make a pre-assumption over that and put that in with where you think that it's going to be. We'll make them a 5, although that's not really fitting with how I assess them. That's okay. Can add in more details. This is a compliance question. And again, nothing is mandatory. So I'm not going to say whether you need to answer this or not, but nothing is mandatory. This is the question that goes back to the National Contact and Tracing System and is about compliance, about fitting with the isolation orders that they are under. We then do allow you to do the vital signs. There was a question about the pulse oximeters and that. This is if they have got them, if they can give you these vitals, you can do that. And one of the things that we've got as well is you can actually put in a retrospective one if that makes sense to be able to put in today that they had that they've got the numbers from a little bit earlier and they can remember them. So we can save and add more, and then we can put in the temperature now as well, and we'll pop in a couple so that we've got it. This is the welfare that goes to the National Contact and Tracing System. Now, if you say yes to this, I will still need to build in a little privacy assessment, privacy banner over here. So on one of the future ones, this will come. But to let you know, this is going back to the National Contact and Tracing System. It will take and give to MSD, Ministry of Social Development, the person's name and the isolation address that they're staying on, and gives the MSD permission to actually phone the person. So please have a conversation with the patient before you actually press this, that they're actually comfortable with that. It's one of the tricks that we're finding regionally as well. But if you do, you can then note what means they have, and that goes into specific queues within the National Contact and Tracing System. When you've said yes, then it opens up. So then now tomorrow when you come, you can check whether the welfare has been in contact or not, and you can check whether they have enough of everything that they need while they are there. Again, a very simple follow-up. Follow-up notes, free text field that you would need over here. I'm going to leave it there, and we're going to complete our health check at this point. I'm going to sneak back to the summary screen because now it gets a little bit more interesting. I hope it gets a little bit more interesting. So now you can actually see that the first assessment has been done, and it gives you a summary. It's got the symptoms over there, and it builds a checklist over time so that you can see the symptoms, you can see the acuity, and you can see that. And this is the plan guideline that Christine mentioned. And so it's actually the initial health check final thing. You can then add to this, and it will save there. And then the next person can come and can see what has been happening over there. Another nice little trick is that you can click on that, and that gives you the good old-fashioned TPR chart. It is defaulting to every single day. If you want to just see today's date, you would just hit current day. Not very exciting here because I've only put the 2 symptoms in for today. If you do phone them and you just want ad hoc vitals, you can add them over there. But as we've said, again, going back and seeing that the notes is quite good. Another probably nice trick for young players is you'll notice that there are lots of different types and they're different colors, and you might want to hone down onto the regular health checks. And so you can click that and probably do that there. So the time of doing the assessment, I think you've seen how we've done it. We kind of knew that person, we were chatting to them, we could fill that in. Certainly, I've done many initial assessment in the isolation facilities now, because generally when I rolled out, I rolled it out and then did lots of initial assessments. And it would take me about 10 to 15 minutes to absolutely cold on the people. I think if you know the person, you could probably do that assessment in 5 to 10 minutes, to be perfectly fair. There is a little bit of, sorry, go.
I was just going to say, somebody's asked the question about sending it to the GP. So if you're not the usual GP, and how do you get the notes back into your system, Lara? Would you like to just talk about that?
Oh, absolutely. So there's lots more to do over here, but you'll notice that there's this complete session button over here. So if I press that complete session button over there, it gives me a forbidden error, which is never a lot of fun. So one moment, caller. And what I'm going to do is just open up another one and actually show you that happening properly, hopefully.
Just because we're in a test system.
And it is very much because we're in a test system. So you notice I've gone immediately to the production system. So I do complete over there. And what it should give us is a nice little thing that it says data saved to the EMR succeeded. Bad languaging, but that's what it is. And then what you can see over here is that it actually saves in the person's outbox, in the patient's outbox. It does save, I do admit this is the world's ugliest PDF. And so I will work very hard to make this the world's second ugliest PDF quite soon. But what it does do is it gives you the full summary of everything that is there. And so each one is the full summary, which means all you need to do is look at the last one to see the history and everything that you're going. So again, work that we'll think about saving just a daily summary and then letting you choose to do the full summary if that's what you'd like to do. Christine, where would you like me to go next? If you don't mind, a very quick view of the person information. What this is you'll notice it's almost like a dashboard. These are the people who are in the bubble. So they do need to be linked to the National Contact and Tracing System to be in that bubble. That's what that unique number is, the bubble number over there. But it does allow you to see the other person over there, see their whiteboard notes, see where they are, see if they've got any tasks pending for the other person as well as your person, view test results, see the acuity score and see the number of vaccinations. It also gives you a little summary here. You'll notice that I've filled in that, and that's one of the values of doing that. It gives you a nice little summary around about the person that you can see over there. The next important thing is the phone number, and being able to validate the phone number is really good, and putting in the email, because going forward, we want to start offering self-reporting bits and pieces, and having these correct is of huge value. This is where...
So somebody's just asked the question about, do we have to do one for everyone who's in acuity 1 to 4? That's a really good question, because what's coming next week is some new tech, which is going to allow you to put them onto other options of care, and the ability for a positive text message to then land them and so that they're able to self-serve. So that's going to really help to complement the system.
Good.
Have you got any more about that, Lara, about the self-serve and where it fits with this?
The self-serve predominantly fits as a public health level, and we'll be bringing that over there. The self-reporting, where you can actually answer the questions for the symptoms, is going to take just a little bit longer, where we still need to do the security assessment on the app that we've got being built.
Yep, so I'm seeing quite a few people saying that GPs and practices are already working extremely hard and feeling pretty frazzled. Yeah. And we're very aware of that, very aware of that, and actually very aware of the whole health system feeling under the pump. And so there is a lot of work going on to try and alleviate that by making sure that people who have low symptoms and are at low risk are able to be very much into a self-serve easy care pathway that does not require intensive support from primary care or anyone else.
Now, we've gone through and we've shown you how to do the acuity scale on the regular health check. You can actually, if you wanted to change it over there, you could change it over there, and you could leave a reason why you've changed it. That will then be quite nice. And I just very quickly jump to the timeline to show you that all of that is actually written there and audited. Again, I'm in a test patient who's been in isolation for 33 days, which is the other problem. I think what I'd like to do now, Christine, is take to the task, because we really want to show how to do the oximeter.
Yeah, the tasks are really important because this is how you communicate what you need for your patient, what you need us to do to move them around, to get oximeters and things like that. Yeah.
So we can write, the subject allows you to write, it's free text, it allows you to write what you like. A start date and end date, the quickest way to do this is to pop that in, and probably to pop both of them over there. The status that it's in progress because you've started it. The priority, is it normal or high priority? It's the same thing, urgent, those bits and pieces. And we're putting this as an administrative task.
Yeah. And on the health pathway, as I showed you, it tells you exactly what to enter into those when you need an oximeter, what to enter.
Excellent. And then just remember to add the task, and then you can see that it's added over there. This then does allow you to come back and add notes at any time, and it does allow you to come here and actually do completed and leave a note as to why it's completed and saved. One of the other fun things about the tasks over here, and I'm looking desperately for one, I can't actually see one in this person, that's okay, I'll talk to it. Within the National Contact and Tracing System, they can also rate tasks for the MSD, for the Ministry of Social Development. And if they do that, you'll actually see a welfare task come in here that you can't edit, and that will slowly update as the MSD actually update their task in NCTS. It'll come back and show you over here so that they can actually, you can actually see what's going on within there as well. Christina, I think just the flags for active management and the yellow flag, is that?
I think that's it. Yes, I think that's it. Thank you, Lara. Yep. So, so we've had a lot of feedback from the PHOs on general practice behalf that practices will, in many cases, appreciate the support at the weekends to do that acuity 5 and 6 clinical core, whereas suspecting that most acuity 1s are for them only mildly unwell, and most of them will not need a call at the weekend, but we know the 5s and 6s might be more concerning because they're more moderately unwell. So we're going to support that at the NRHCC hub by enabling practices to select to do the care during the week, during business hours, when they might have perhaps nursing staff available to be able to put to this, to be able to do this task of providing that care. And we're hoping that it will only be a trickle of people to start off with, and that you're in here, you'll be able to raise a flag, which is called a yellow flag, which is coming overnight. So you go into clinical encounter, you raise, oh, there it is, beautiful yellow flag. The yellow flag is the flag to ask for clinical review at the weekend, and you can add some extra notes here to the right. You might want something personalized for that person, that you want that caller to know about that person. Such, I'm worried about the husband, or you know, he's not, he seemed to be starting to get some symptoms, and I asked them to get a test. Can you just check out and make sure they've done that, or something or other, you know, all those sorts of things, you know, that you might add there. And that's how you'll raise it, and that's how we'll find it to do that assessment at the weekend on the practice's behalf.
So just showing them very rapidly, that's your dashboard, and that allows them to see the yellow and to filter by the yellow.
Okay, so and the teams that we're going to have doing this, many of them have been the staff doing managed isolation facilities as well, so they're very familiar with this and very familiar with COVID symptoms. Great. So that's really, I think once you get in there and you start to use the system, you'll find it pretty straightforward, just to do the basic things you need to do with that initial assessment, and then to do the daily reviews if you're going to do daily reviews, particularly focusing on those people with higher needs.
Christine, yep. A couple of questions about, does it work in this practice management versus that? It is practice management independent. It is based on you having access to the HealthLink forms and us giving your EDI access to this. The way that the EDI has worked is that the GP college has worked with the Ministry of Health and have said, yes, all of those with your foundation standards and all those with elapsed foundation standards, we've already enabled it. I think certainly for Auckland region, Christine then found the couple that had no, and we enabled those after the 15 questions. So if anybody doesn't have that, contact Border Apps at contacttracing.com, and we will send you the 15 questions and we'll enable it for you very rapidly. The other question that came up is, can you access TestSafe? Now, TestSafe is on Connected Health, so it does depend on the network that you're on. So if you're on a computer that normally accesses TestSafe, this will work in exactly the same way you can open. But I do think carefully about it. It's tried to be the same and allow you to do that because it was standalone. But while you're in your practice management system, think through what the workflow is and which way is easiest for you to do that.
Okay, so I think that's a really quick summary of how to do that, which is fantastic. Thank you, Lara. I'm just looking through the questions that we've had.
The one important one that I can see, Christine, is there is payment attached to completing the CCCM.
Yes. Yes, there is payment attached to it, and we'll show a slide of that. And Lara and colleagues have done some magic with that in behind. So because this is every time you're doing this, it is creating parts being filled out in the CCCM. They have devised a way of being able to pay practices for the care that has been provided through POAC, but without having to submit a claim. Is that correct, Lara? You've been working really hard on that.
That's correct. So very much the same way that we did with those e-notifications, and I know you don't love them, but there is an e-collection module if you want to work to that, but it did save you having to cope with a claim. So in the same way that we did that magic, we're going to do exactly the same way with this, and we've worked out with the standards. We can see when you've gone in, when you've made notes. That's probably the one task that we need to talk about, is the nurse escalating to the doctor. That is probably best put as a clinical review task as well. We will know how you've done those things. Again, more information coming, and we'll be able to pay you, and we'll do it at the end of the case rather than per day. We'll summarize it up and do a payment to you that way. So very much public funding, planning and funding, and magic in the Northern Region health team is to thank for that.
So it goes back to those people who received the medals last night. This is the funding that has come out from the Ministry of Health. It was somewhat more based on Delta approach. However, this is the funding approach that is in place with the Ministry of Health. And there are some notes that go along with this, but just to say that came out with the Medins yesterday, there is the standard price for that initial assessment and the high needs assessment, but recognising in the initial assessment you do need to do some assessment of the bubble. So you need to let that person know that they're positive, because the contact tracing may not have contacted them yet. So you will be letting them know. You need to let the family know, or the household know, that they need to isolate, and that the contact tracing team will be phoning them to talk them through what's required for there. They will need to get testing if they're not already been tested, and then they will be told when they next need to be tested after that. So there are some things involved in the initial assessment which are to do with that bubble, but then subsequent to that, that really is becoming more, you're only being paid for the case after that, if that makes sense. And then just takes you through the funding according to the acuity, recognising those 5s and 6s are going to need more care. Those people with more mild symptoms, if you need to, you can do those ongoing case reviews, and you could set them at a much lower frequency. If you still think they need a call in, they might need a reminder at day 5 for the rest of the family or the rest of the household to go to the testing centre to get their testing done, or they can come to the practice if you have a way of doing that, knowing that they may be COVID positive. And then there is the care associated with when you might need to escalate it. So practices in general tend to make this a nurse-led, and some practices are also making it a healthcare assistant-led piece of work, but then you may need to escalate up the care to a nurse practitioner or a GP, and so that is also attracts a payment. If you need to do in-person care, that can either be in the clinic or in the home. Okay. And then also there is a case discharge. So at this point in time, the person needs to be discharged from the COVID clinical care module, and that requires finalising the report, which is final health check, which is on one of those pages, Lara, you probably know off the top of your head, of the
regular health check.
It's the final page of the regular health check, and it just requires clicking on there, and then we know that that person's record has finished. Okay, I'm going to stop sharing there because I think that it's time for Rawiri, if Rawiri's joined us.
Kia ora. So there's a Māori regional coordination hub. I think everybody will know that during Delta, there was a very significant increased mortality for Māori. We're really interested in making sure that we have a system that meets the needs of Māori, and to every extent possible, we don't have any more Māori deaths. So the Māori Coordination Hub will get all of the Māori cases in the Auckland region and sort them out into high, medium and low clinical risk, and then sort out the manaaki and welfare, and then pass the ongoing clinical care to either the patient's GP, where they elect that and the GP is actively providing community COVID care, or to a Māori provider, or we'll identify a provider of last resort. This slide really just talks to the numbers. If we have the expected 1,800 cases per day in Auckland, and so we've got capacity to do all of the high risk and medium risk cases. Next slide shows what we will need to do if daily cases exceed 1,800 cases per day. So we're predicting something like 20 to 25% of cases will be Māori. And if the cases per day surge to this extent, then we will need to organise some of the lower risk Māori cases to get the telehealth provider supported services with sort of no touch, low touch models. And once we've worked it out, the third slide shows you the kind of outcomes we've got in terms of the clinical management, the manaaki and welfare management, and we are working through the public health stuff, making sure that we've got clarity for whānau about their isolation requirements. We're identifying any critical workers who are working in border and healthcare settings or work for utilities companies. Pretty important to get through this, and so we'll fulfil the remaining public health requirement. That's me, over.
Thanks, Rawiri. Back to you, Christine.
Okay, so thank you, Rawiri, and it's really just explaining the Māori Regional Coordination Hub, which really has that power screening assessment to really understand whānau's needs. And it's been really, really critical during the Delta outbreak to really assist whānau to understand what they need to do around isolation and supporting them with the needs that they had during isolation. So really important. And then we have the Pacific Regional Coordination Hub, which works slightly differently. So they have quite a number of Pacifica providers who are providing care to Pacifica communities and have quite a lot of experience through both the previous outbreaks, really, in understanding how to support whole communities around isolating effectively, and really supporting the needs of their own communities. And it's really the challenge ahead is knowing how that they can be scaled up and continue to do that support for the communities which we know are hit hard when we have COVID in the community. So I think I've seen a few questions there from people who feel like this has been a bit abrupt. It has been in planning that we're handing over to primary care to do some of the work now for a number of months. And yes, I realise that people are working really, really hard. What I would say to you is that what we mean by a soft launch is that we do have a safety net at this point in time. So if you haven't picked up your cases today, it's okay. We've got them. They are sitting with whakarangaro who will continue to do that, but they only have a certain capacity, and we're getting quite close to that capacity. We're likely to hit that next week at some stage during the week. And so it's really important that we are able to share the load across the system and be able to address people's needs. But it is important that our effort is proportionate to what they actually need, and that we're not doing more than they need. So appreciate the questions and happy to take questions now. I know that there are a lot there. So we've got a question here. So we can't start offering shared care until whānau HQ and whakarangaro have assessed? No, that's not the case. You can go ahead and you can offer Certainly you can ring your patients and let them know that they have COVID and meet their immediate needs through doing that initial assessment. And if you communicate with us through that tasking, we'll know that you've got them. Okay, and that will be really, really helpful. And then we will make sure that we take them out of Whakarangaro's bucket and put them in the primary care facility for Auckland, and we'll know that you as the primary care practice are taking care of that patient. So that's how you message us to let us know that you've got them. At the moment, we need that positive messaging because we can't leave people hanging, if that makes sense.
Does a COVID positive patient isolate in a different room to contacts from the same bubble?
So it's a really good question, and a lot of people have been asking about that. I mean, certainly thinking about children, of course, you cannot isolate separate to your children. You must take care of your children, and it doesn't make sense to isolate away from them. It may not make sense to isolate away from other family members as well. And, you know, a little bit of common sense as to whether or not people have already been significantly exposed anyway, or whether it is actually practical within a household to isolate away completely. But we do have the contact tracing teams who are also talking to people who can provide further advice on that. We are not expecting you to be the contact tracing experts. Let them know at this stage that the contact tracing team will still be in contact with them and they will talk them through this. Okay.
How are we to know who the LMC is? Most of the time we have no idea as women choose those independently. Presumably you would have talked to the patient.
Yeah, exactly. Talk to the patient and ask them to please let the LMC know. Yep, sensible.
Okay.
Yep.
A question from Harley here. So we can't start offering shared care until Whānau HQ and WA have been assessed?
So that was the question I was answering before. So as soon as there is that CCM record there, which you'll know from that COVID case in form, you can initiate care with your people. So what we're doing, instead of waiting for contact tracing to occur and then progressing on to clinical care, we're now going in parallel to make sure that we can provide that clinical care earlier to people. Our experience is as the numbers start to surge that the test results take longer to come through, and then it goes through a contact tracing process, and that can actually cause quite a delay to actually providing clinical care. So we're really keen that you engage early and that you find out what people need. If they don't need much, that's fine. They know how to get hold of you if they need you. But really important that we find those people who are more unwell quickly, and we're able to support those people who are more unwell. So please do engage. We're really keen on it. There were a few hiccups today, but that should smooth out over the next few days.
Fijian Indians welcome in Pacific hubs?
I will need to inquire with the Pacifica team. I'll have to get back to you on that one.
Okay, who is directly responsible for the delivery of care via CCMS? Is this a GP or nurse role? Who is ultimately accountable?
So just like we do most care within primary care practices, it's a team environment, and clearly deciding who is most appropriate to do that care is the practice decision. And I'm quite happy with that, being a GP myself, that practices are very good at sorting that out within their own teams. And I think you're well supported with a health pathway as the information that you require. I hope that answers that sufficiently, but I think that you know the capabilities of your teams, and it's really important that you make practice decisions about how you do this.
Does fully vaccinated equal 2+ booster? Where does the person with one vaccine sit? Some immunocompromised will be fully vaccinated.
Yes, so it's a tricky one, isn't it? Because the definitions keep changing of what's fully vaccinated is. So it had been fully vaccinated as 2 doses. Now we're talking about people having boosters. Immunocompromised, we're talking about a 3rd dose and a booster. The upshot of it all is if at least you've had 1 dose of a vaccine, you're a lot better off from hospitalisation. If you've had 2 doses and a booster, you're in a much, much, much better position. And people who are immunocompromised, well, it really just depends how immunocompromised they are. But once they've had their 3rd dose, then they are in a much better position. Obviously, we can't cover every possible nuance, but actually any doses start to chip away at that risk of hospitalisation. Having the booster all completed makes a massive difference.
Buying batteries for pulse oximeters, they're the new toilet paper. Any reliable sources?
The pulse oximeters that get sent out are checked before they go out to make sure that they've got fresh batteries. We are reserving those for the Acuity 5s and 6s, and Acuity 5 and 6 of course might change during the course of the illness, and you might need to request one at that point in time. Just a word of warning, oximeters may cause more problems than they're worth in people who don't have many symptoms. So just be careful about who you're demanding oximetry recordings on, and use good clinical skills as far as questioning people about hypoxia too. So things like, if you can't get out of bed and go to the loo without getting excessively short of breath, if you're getting excessively short of breath, you can't get up and make a sandwich and things like that. If people are really like that and that's not their usual state of being, you need to be concerned about these people. Omicron and with COVID, particular concerns are people who it tends to cause this sort of dizziness, which may or may not be due to hydration, but the particular dizziness, people fainting and falling, they're concerning. People who are getting confused, because that can be early signs, that can be a sign of hypoxia. People who just can't move around, who are excessively lethargic, these are the people we really need to worry about. Also, of course, those people with sudden chest pains, feeling short of breath and things like that.
Which may not be COVID, of course. Yeah.
Which may not be COVID, but might be COVID related.
Other things still can happen. Do we assume everyone with a positive COVID test is Omicron? Is it tested for? Is everyone going to be tested for?
Yeah, so my current understanding of what's happening in the Auckland region is that people are getting tested as to what the variety is, and although it may not happen in a timely manner because these take a little bit more time to do, but I understand from the intel from this afternoon is they absolutely, I think almost exclusively what's happening in Auckland is Omicron. Other regions have got a bit more Delta, but I'll have to check up on that one and get back to you on that one. But there's a bit of a lag, obviously, and I'll have to just check as far as how much sequencing is going on.
Why the need for a task for an oximeter? Why not just send automatically for all 5 and 6?
It's a good question. Well, they may already have an oximeter. So we don't want to have to send an oximeter if the person's already gone and got their own oximeter, and there are quite a few people out there who've already got their own oximeters. So it may well become a more scarce resource, and so it's really just important that we manage that for the people that need it. So great if people have got their own oximeter, just make sure it's reading sensibly at the outset, and the task will help us to know that you need one,
and so we need to ask if they've got one, presumably. Was that one of the questions?
I think that's a really useful question to ask, is have you already got an oximeter? Because I think a lot of people I've talked to actually went and sourced their own. Yeah.
I think people with chest problems probably have done that, haven't they?
Yeah. So I think that's just sensible. I mean, we shouldn't send one to people we don't need to send one to.
Yep. What happens when different household members have different GP surgeries?
Yeah, so just remember that from a bubble perspective, we're just inquiring generally about the bubble now, trying to troubleshoot anybody who seems to be quite unwell or who's got symptoms who needs to be tested. The bubbles concept has been quite important, but it's also logistically quite challenging. So if that person's not also under the practice and they are now symptomatic, then I suggest either you offer that they are managed by the practice as a casual, non-enrolled, and there is a way to account for that in the funding, or you ask them to phone their own GP to manage them.
A long question here. Acuity 1 to 4 who are older but no comorbidities and live alone. Concerned about this group. If they get sick, may not be contacting us, and no family household members available to see they're getting unwell. Are primary care expected to contact these people at all? Also, who chases them up if they don't follow up tests at low acuity?
Yeah. So in that acuity, you have the ability to set something called high social risk, and being a person living on their own is a high social risk because of the concern about lack of being able to contact people, or people living alone, and what happens if they become more unwell. And so you can set that and use some clinical discretion to set it that way. The other thing, I'm really glad somebody brought up that question, because I hadn't mentioned anything about it, but actually the people who live alone are particularly people that we're really keen that we keep a close eye on. And the ways that you can do that is that ask them whether they have a neighbour that they can wave across the fence at each day that checks they're okay. Have a buddy system in place, okay? You can't possibly manage to phone every single person every day, you know, of those lower acuities, but have a buddy system going on. So ask them to identify somebody who they do normally keep in contact with, that they can keep in contact with, and even identify that person in the notes so that you know who to call if you can't get in hold of them, for example. That's really, really important. And the not able to contacts have formed a big piece of work for the Delta outbreak. And we've found that some of these techniques have really worked and helped to reduce that concern about not.
Worst case scenario, you can even phone the neighbour and just give them a little bit of you know, praise about helping out their neighbour. So that could be a nice social component. Very
I think it's a good preparation that you can do with your patients too. If you're seeing people that you know live alone, say, well, look, if you do end up getting the COVID, who would be your person that you would call? You know, who's going to keep an eye, you know, like keep in touch with you by phone you every day. It's your COVID buddy, the person who's going to keep an eye out for you, know that you're okay, and know who to call if you're not answering.
When can we get advice for the clinical management and support for a positive case?
So what was that? When
and where can we get clinical advice for managing a positive case?
Yes. So obviously the health pathway is the first place to go on how to manage your positive case. But if you're wanting some more information very specific to, you're concerned about this person's symptoms, you think that they might need something specific, then the infectious diseases consultants are very happy to take your call and answer your questions. So that's the COVID-19 advice clinicians. So there's the advice ones there, different to the ones that you would use if you wanted to admit the patient directly.
Is the initial assessment something that can be done over the phone in 15 minutes?
It certainly can, absolutely. Yeah. So when people have been doing, when Whakarangarau or Merch have been doing initial assessments for an entire bubble, they're taken on average about, they take about 40 minutes. But when you already know the patient and you already know quite a lot about them, then I expect that you can do an initial assessment reasonably quickly. Obviously, if you've got a few bubble members to briefly inquire about, then it might take a little bit longer.
So we should print classifications out before completing initial assessment?
So you add within your own practice management system, depends if there are a lot to add. Yeah, I think it unfortunately doesn't quite pull from your practice management system at this point in time, but it's just important to pull across the really important classifications such that if somebody's providing urgent care to your patient, they'll know the main things that they need to be aware of.
For patients and practices registered with Your Health Summary, can we link into initial assessment as more comprehensive than our basic info?
Now, Lara, Your Health Summary and CCCM?
Unfortunately, not a direct link. As you know, we haven't managed to get through the privacy impact assessment with the different people involved in terms of opening that. So we probably need to recircle back around there and try again now that we've shown the value of this.
Yeah. So the MIQ staff, clinical staff have had the access to Your Health Summary. It's been really important from that perspective. But here we are, we've got the usual GP who will be providing the care. So you already know, I would have thought, their person. It is possible that our clinical teams in it, the hub, could have access to Your Health Summary as well, and we've certainly made that available to Whakarangarau as well, although I'm not too sure how often they're opening that, because we've had triage staff adding clinical history into the notes already. So as a normal GP, I'm sure you already know what the person's classifications are.
Do we have to fill in CCCM for 1 to 4 acuity patients as well?
At this stage, I would suggest yes, because we don't have the self-serve model up and going. But once we start to get that going, then I think that will be fine. I think that's the way you're going to get funded. So if you do an initial assessment and there are 1 to 4, and then you say, okay, it's fine, you can self-manage, you'll get paid for that initial assessment. And I would, at this point in time, because you don't really know what acuity they are until you've spoken to them at this point.
Okay. Can you do a practice with Mickey Mouse on your computer?
Yes, and there was a question there, and I typed in the 3 ZZZs that are available for that. I think what I can do is put that in an email, Bruce, and maybe we can, so it is in the chat, the 3 ZZZs, which is 0164, I forget the other ones, but there are 3 of them in live system that you can go and play in, and I have answered them in the chat a little bit earlier.
I wonder if we might put them on the health pathway, Lara, so that people know the play patients. Yeah,
good idea. I'll send you the details. Yeah,
and that's a really good idea if you hadn't had any cases yet, because it allows you to look around the system without having cases yet. Yeah.
Does the information a patient enters override our data? Does it identify who entered the data?
It does identify who enters the data in behind, and that's how we know how to pay you. Does it overwrite your practice management system data? No. And actually that reminds me of a question, sorry, little tangential, but it reminds me of a question that somebody had already asked, is how do you give tasks to other practice members, such as if you're off on your next day and you need somebody else to do the call for you the next day. I suggest you set a task within your own practice management system, and I suggest you think about within your practice setting up a task list for COVID care. And that if you have, for example, a nurse assigned to doing the COVID care calls on a daily basis, that you have that kind of COVID task list set up, and that you use that within your own practice management system to set that up. That makes sense?
Also integrate NZEPS into the info at meds. Does that make sense?
It does. I'm very aware that I've got this free text field that says current medications, and that I do actually have access to the New Zealand electronic prescribing system, and that I should be able to just automatically fill it in for you. I'm going to work on that after this go live tonight. So I hope to have that quite soon.
Just a thought here about 30 minutes per patient. How are we going to manage when we have hundreds of cases and still try to see our regular patients?
Yeah.
Any comment on that?
Yeah, no, a really valid concern. And what I would say is what's coming is self-serve. So we expect in a highly vaccinated population, the majority of people who get COVID will actually be pretty well and low risk. And the self-serve options that are coming up are going to be incredibly helpful to assist with that workload, such as we really want to concentrate the workload on and it will be work, there's no doubt about it, on those people who are more moderately unwell. So we're actively working towards that, and you'll see developments coming up in the next few weeks that would really help to assist with that and unburden the system.
What do you want us to put into the patient's plan?
The plan. Are we going to contact them daily? What needs to be asked tomorrow? What do we need to think about going forward? Is this those bits and pieces? It is the same, assessment that you would do in your normal SOAP notes.
You know, Sally lives alone, and I've arranged for the neighbour Bob next door to give her a call each day, or she's arranged for Bob next door to give her a call each day. Those sort of things are really, really helpful when things don't go right, because then you know what to do. So those sorts of things are really helpful. You might give a little bit more description of the symptoms, or if their clinical care is going to be done by the hub at the weekend, you might need a little bit more information, specifically, you know, this was the particular problems today, and this is what I want you to particularly look out for at the weekend, sort of thing. You know, those things are really, really helpful when you think that you're handing over to a clinician that doesn't know that person at the weekend. It does help if we have some familiar information, that in order to carry on that conversation with the person, really helpful. I
guess it's thinking about what you would want to know if you were the one taking over the care. So
absolutely.
It's that sort of step. I notice there's an option to send notes back to GP. I presume we could send this back to ourselves, so it's saved into our PMS.
So you could. There's a little trick for young players. It's the note itself. It's not the entire record that you send. You'd have to go into the clinical encounter and send the full record. But that note goes to your inbox. which means you have to file it. So generally what quite a lot of people are doing across the country is the hubs, and some GPs are looking after the patients. And if they want to inform the nursing staff or the healthcare assistants are doing it, if they want the GP to do something, they send a note to the GP that way that says, please do something. They get the inbox note, they go in via practice management system, do the answer to it and close down. And in that way, the regional team actually knows what is going on. So that notes to GP, I would use for an action to the GP rather than to send you the notes. When I clicked complete session, it actually saved the full summary to your notes in the patient outbox in the web form. And if you wanted that, but you were working outside of the patient management system, there is a full summary. God, it's a stupid word. There is the full record that you can send that way as well. But again, it will go into the inbox and not the outbox. And Daniel will hurt me if you get too many inbox messages.
Okay, for the initial assessment, can it be done by GPs, NPs or nurses?
Any of the above.
Any above, good, okay. Can you please show us how to access the acuity score?
Yes, it's on Health Pathways. So, so if you want to know how to do the acuity score, how to set the acuity score, it's in the middle of the Health Pathway under acuity score. And we showed you within the CCCM, it's on the daily health check page.
It's on the banner right at the top. You can take it over there, but on the regular check, when you've got through the questions, it's there as well.
Yeah,
and
I think it's on page 3. I think it's on page 3. Yep.
Yeah, it's after you've done the questions.
Yep.
Is there an expectation for daily assessments for all, or just acuity 5 and 6?
Just the acuity 5 and 6. And look, it's up to you to decide what you need to do clinically. I would suggest daily is required for the 5s and 6s, just to keep an eye on them, unless it's a lady who's pregnant, who you've gotten 5 and 6 and you've managed to get across and do all the bits that you need to do for that pregnancy care, and you're satisfied that she is well and managing really well, then obviously you'd make clinical discretion and decide you could do that less frequently. And there may be other reasons other than the severity of COVID why you might put them in 5 or 6. So some people might have had a few days stay in hospital for some other reason but have COVID, and there might be a reason why actually you don't need to ring them every day. So some clinical discretion is absolutely fine within that, but in general, if you wanted to set a rule, then daily is reasonable for the 5s and 6s, but certainly the 1s to 4s, I would try to step back at it. Whakaranganui have decided that the 1s and 2s, they're going to try and set free into self-management. When I say set free, okay, they're in isolation, but they are not needing to be called every day. And the 3s and 4s, they're going to call alternate days. So if you want to know what they're doing, that's the plan they're doing. They're very systematized. It doesn't have the degree of personalization that you can do in a primary care practice.
Just a clarification of that question about GP, nurse practitioner. Apparently may have been different over Delta. I think we're just assuming everybody's Omicron now, aren't we? Rather than Delta, there's going to be no distinction there.
As Prof Blakely says, go for a pure Omicron experience. It seems like we're heading that way in Auckland.
Okay, okay. Is there a question to confirm or change the address the person is isolating in? Or is the registered address we have self-populating?
Good question. So in the self-serve, the person will put in their own isolation address. If they've been contacted by contact tracing, they've got 2 addresses, the home address and the self-isolation address. It is the self-isolation address that comes through on the person information screen. It's on the 3rd tab of the person information screen. If it is wrong, you can update it over there.
So does acuity need to be calculated outside of the CCM using the flow chart in order to be entered, or does it self-populate in the CCM depending on your entered assessments?
So currently you have to populate it, but there's future plans to help with that. Is that reasonable, Lara?
That's reasonable because it's getting a lot of national traction, and this is it. The more we can get things nationally, the more likely we are to build it in. Somebody did say, why not have that chart, your rather nice table, accessible in the Board of Clinical Management System. I've taken that down as something else, see what I can do in the next sprint, because that should be quite a quick and easy thing to do.
If we see patients for more than just COVID and need to record other notes in our usual PMS, is there a way to quickly export notes from CCCM? The
best way would be that clinical tile and that full summary that will give you that rather ugly PDF at the moment, but that will be the best way to export everything that's been done about the person. That was the intention of it when it was built.
Yeah, so the intention is that you do generate that summary into the outbox each time that you do the assessment. So then you've got the record in your PMS system that you've done that. And so that is your record back in your PMS system of what you've done.
Can you see all your patients that are active on one screen?
So this is a tricky one because this was built to do exactly that. It has a dashboard view and then an inpatient context. We have sold you for a cheap price. We have sold you the inpatient context to go into from your patient management system to go in the in context. So you do need access to a dashboard in order to see that list of patients. Otherwise, you will need to do tasks or reminders in your own patient management system. I am working very hard to do a practice-based dashboard, which would use your EDI and then would link all the patients with that EDI onto a dashboard, and you'd be able to access it like that. But I will take a little while to be able to invent that, I'm afraid.
Is payment attached to completing the CCM?
Yes.
Okay. Okay, so what about small practices that does not have the means to get this done? What do they do? We are only 3 full-time staff members, 1 GP, 1 practice management, 1 RN.
Yeah, so certainly practices can have a talk and huddle about what they can and can't do. They think they can and can't do. At this stage, as I said, we have a backup in the sense that patients will just progress down the whakarangaro line if they are not Māori or Pacific. And recognising that at various times practices will find that they are struggling to keep up with all the things that they need to do. However, we do encourage the practices that can to please get involved, because we do need to share across the system the load. So yeah, we recognise that some practices it will be a real struggle, but I do encourage you to engage with it and just see what you can do, because I think once you get into it, you'll find it reasonably straightforward. And if you only have a trickle of patients, because you are, you know, a smaller practice, just depends on the patient, the loads of patients coming through. But I just do encourage practices to have a bit of a look at it and see whether they can potentially manage it. Because we can't manufacture a whole lot of clinical staff out of nowhere, and we know that we're going to hit. We're pretty certain we're going to hit big numbers. So yeah, I think it's tricky to know how we're going to manage this otherwise.
Just a question here about our PMS. You cannot have both HealthLink form open and access the PMS unless data pre-populates, we cannot get back to PMS to check any data.
Yeah. Good question. So we have opened it in line, specifically because security and privacy asked us to open it in line. But what you're asking for is, could we open it in a new window? Can I take that away and talk with the HealthLink and with the security and the privacy teams?
I think that was the question before. Somebody said, should I print the classifications before I open it so that I know what to put into them?
Right.
Yeah.
A couple of questions about payments. What are the payment amounts and how do we audit the payments are correct?
Yeah, thank you. So the payment amounts were on the Medins last night, and we'll put some more information available in the funding part on Health Pathways. So that will be coming in the next days or so. We were just confirming the ability to pay it the way that we're going to out of the CCCM, and that has all been confirmed now. So there's a question also about whether or not we should retrospectively do the cases from, 3 or 4 days ago. We have just asked you to take the cases going forward, not the retrospectively.
Okay.
But I would remind people that the old funding framework has been in place since the Delta outbreak. So that's still claimable through POEC if you're using the old ways of doing things.
Okay. Can I claim retrospectively for those we actioned today, for example?
So we will know what you've done in the system if you've done it in the CCM system. If you haven't done it in the CCM system, because I know some people had difficulty accessing it, then you can claim it through POEC in the system that had already been in place for Delta.
Our Auckland CBD clinic has lots of non-eligible patients, i.e. visitor international students. How do clinic get notification, positive case, and how does funding work for these groups?
So they're not getting positive notifications into the inbox?
The positive notification only goes to the enrolled GP. So if those people are not enrolled with them, they won't be getting any notification. If they're testing them and they are the result, they are the tester, they'll obviously get that result.
So a non-enrolled person might go for whakauraho, would it?
Yes, so whakarangaro, certainly in the stratification process and auto allocation that will happen from the end of next week, the non-enrolled, non-Māori and non-Pacific will automatically go to whakarangaro.
So somebody in self-care, do you still contact them for a case closing discharge?
Yeah, so at this stage you need to. It's a bit of a frustrating thing, but we're expecting with the change of phasing to phase 2, which we anticipate will probably be in the next week, those isolation periods change and it's no longer a formal process. So I just do admit I'm doing a little bit of crossing my fingers and hoping we go to phase 2 before that becomes a problem for the cases that are currently coming up in the next days. Sorry, that sounds like an odd response, but I'm crossing my fingers and hoping because the release process has been painful, as many GPs know.
Yep. There was something about the brackets with in terms of the prices.
Yes, thank you. The brackets are the after hours payments. So after hours is after 8 p.m. Monday to Thursday, after 5 p.m. Friday until 8 a.m. on Monday, and for public holidays.
Can other people get the resources if they're not Māori?
So that's assistance with welfare and so forth. Yes, they can. It just won't be through Merch or Patch. So it won't be through the Māori Regional Coordination Hub or the Pacific Regional Coordination Hub, but if they are needing welfare resources and so forth, just like Lara showed you how to do that on CCCM, you can request that.
Okay. Right. Do we need to put aside slots for COVID patients each day, like have a few gaps? Any suggestions there, Christine?
Yeah, you'll know how many positives you got coming into your practice at the moment, and we do expect that to continue. And I would suggest, you know, just based on what you currently have, you might realise actually you're expecting a few more within that bubble, for example. I think that it's worthwhile planning, depending on the size of your practice, about how much resource you might need to put aside to do this kind of activity. And I would suggest that it is a nurse-led activity in the main. I think it's worthwhile considering that as a practice, depending on your size.
Christine, we have 90 questions to go. Shall we keep going till 9:15? What do you suggest?
We've still got 700 or so people on.
Yep. So let's keep going.
So it's my poor colleagues here staying very late, but that's okay. If they're okay, I'm okay.
Okay, can you explain the budesonide treatment further? Like when would you start? Who would you start it on?
Okay, so you'll find that information in the health pathways and the budesonide drop box there in the health pathways. So it's got clear criteria there, and the idea is to get going on it if you think that that patient needs it. So they're, you know, at least mildly symptomatic and possibly likely to deteriorate based on your knowledge of that patient. So I would just suggest you follow that drop box and prescribe that budesonide according to the criteria in that drop box.
A patient asking for throaties thought they'd be subsidised. He was told it would be free. Are they going to offer free medications?
So the 150 pharmacies throughout Auckland have the ability to deliver medications to support people with COVID. I guess the question is whether the throaties are prescribed medications. I think the answer is probably no. But look, I'll have to ask Daniel a bit more about the extent of what pharmacies can provide. But they can certainly deliver medications that a patient requires. There's 150 pharmacies who have agreed to do that free of charge.
Is there a way to filter, highlight out COVID community cases so that they don't sit amongst all the other inbox results?
This is an age-old inbox problem, is it not? Don't know that I've got a good answer for that. But
so I think that this is looking within your own practice management system. You can look at all providers, and then you look for the red SARS-CoV-2 result. So it should be reasonably clear, I would have thought. But look, sorry, I don't know all the practice management systems inside out and back to front. It's exactly how you could sort that. But yeah, I think just would have to seek some more expertise on that one.
Is there much point stepping in as patient's GP once whānau HQ has been engaged without their specific request?
I'm just trying to understand the question there. So
let's say whānau HQ gets involved, maybe there's a delay. Can the GP sort of be involved at that point, or is it already have the wheels started turning with whānau HQ?
So whakarangarau would be the alternative provider if it's not a Māori or Pacifica provider.
Right.
And so the whānau HQ clinical care is really to service the after, the weekend outbound calling. So if your patient needs a call at the weekend, they'll do the outbound calling. Is it worthwhile? Certainly if your patient would like you to, I encourage you to, and if you've got capacity to. And I do know that this has already been happening. I know a lot of GPs have been involved in their patients who've had COVID over the Delta outbreak and have been providing support and care to their patients. It's not predetermined whether or not you can pick up at any stage. That's what I would say. As long as you task us and let us know that you're doing it so that we don't duplicate care. That makes sense. It kind of makes more sense to a patient if only one person's calling them at a time.
If a traveller came from overseas and self-isolating, what about their family members? They are not self-isolating and exposing others at workplace.
So I'm not a contact tracing expert here, and I would have to defer to my public health colleagues on that one. So,
are we able to admit without a clinical face-to-face review, or do we need home visits?
No, you do not need to do a home visit or a face-to-face to review. If you feel, you've got an oximetry result, which is 92%, the person's feeling worse, hypoxia is a clear indication for admission, and the general feedback from our clinicians at the hospital is they'd absolutely want to see those people in hospital. Okay, and that's actually the feedback I'd have from the Delta outbreak, is that very few people actually, over the 10,000 cases, actually needed an in-person review who didn't need hospital.
Healthcare assistants, can they do the initial assessment?
I think it depends on the training that you provide to your healthcare assistants and the support that you provide to your healthcare assistants. We actually discussed this at our clinical governance group this afternoon about that, and it very much depends on the training and support that you provide healthcare workers.
Question here talking about day 5 to 8 danger time for developing lung edema. That's different, I think, with Omicron, but we just have to watch people anyway.
Yeah,
would that be right?
Yeah, that is right. And look, next week we're going to have a webinar with our experts. You'll remember Tim Cutfield that's joined us on a number of occasions, and we're going to bring in more of our secondary care colleagues that are going to talk about some of the common things that are occurring with COVID and things that are commonly asked questions. So we really encourage you to join in with that, and that's going to be more peer support, really peer sort of level, ask you questions, get the answers, and really keen to really engage primary care with those sessions to make sure that we're all learning at the same time, and prepare ourselves for looking after our COVID positive patients.
Are there translators available at whānau HQ?
Certainly they're available through whakarangarau, and we will look to how we can make translators available. But just remember for the clinical assessments that we need to do at the weekends, but just remember that we're not in general taking on other clinical care during the week, if that makes sense. But whakarangarau certainly have availability of a number of translators. They have a lot of workers who speak a number of languages. So, yeah. But just remember, you can use your own usual processes within the practice if you normally use translating services.
Okay. A patient dashboard. We don't have one in our PMS. How can we get a list
of your patients? And that's what I was suggesting. Lara's just talked about that before, about trying to create the dashboard for your COVID positive patients within the practice. It's not yet available, and I suggest that you create, talk in your practice about how you might create a task list within your own practice management system of the patients with the positive results that need to be sorted. If you choose to do a coordinated response within your practice, perhaps have somebody set to that task each day.
A patient came with symptoms, runny nose, but refused to take swab, only asking for rest and medical certificate. What should we do?
Sorry, repeat the question, Bruce.
Patient refuses to take a swab, so they've got respiratory symptoms, and they you don't know if they've actually got COVID or not.
Yeah.
They want a medical certificate.
Yeah, tough position, hey. Yeah, one of those tough ones, because you really want them to have a swab to know whether or not it's COVID. And if they're not going to have a swab, we really kind of feel like they need to be self-isolating, and probably their bubble too. Tricky problem. Yeah.
The COVID-19 results coming into inbox with multiple subject headings, 5 by my count. Respiratory testing, I know I've seen at least 2. SARS, COVID, PCR. Can the lab get it into a single one?
I think that might be a problem with different labs doing it, Lara. Is that correct?
I'm going to defend the labs a little bit now. It is actually very much how you ask for the test as to what the lab ends up giving you. And I think inadvertently you probably are asking for full panels and for those sorts of things, because generally the lab does exactly what they're told to do. They have very little clinical discretion here. Sorry, I just felt I needed to defend my laboratory friends there a bit.
Charlotte Harris giving you guys a thumbs up. So nice to hear that, Charlotte.
Thanks, Charlotte.
Yeah, these guys are needing a bit of a boost, you know, maybe a Red Bull or something, like the ad says.
Yeah. How many questions we've got to go, Bruce? Or should we take those away, and we'll do our best to answer them on health pathways? We'll try and theme them up.
That sounds very noble on your part. Yeah. Okay. So anyway, well, thank you very much, Christine. I think this has been a pretty hands-on practical session. We're going to be having regular Thursday tutorials dealing with various situations that will be arising. So there will be more opportunities. And I think people will have got to grips with the system by then much more. So thanks very much.
I was going to say,
Lara,
sorry, Bruce, I was just interrupting. I was going to say our secondary care colleagues are really desperate to help. They really are very, very keen to share knowledge and so forth, and they really understand that primary care are under the hammer at the moment. So, and they are incredibly willing to spend time with primary care to really answer your questions. So we'll engage them into the next one. Looking forward to it.
So the tutorials will be about acute management, children, pregnant women, long COVID. So they'll be pretty interesting. So it is going to require a commitment of time, but they're all recorded, available by midday the next day. So you don't actually have to spend your evenings if you want to, but you will have to put time aside for that. So thank you very much for the audience. You've got a big task coming up. Let's hope the curve is relatively flat, but the numbers going up today is a bit of a worry, but a matter of wait and see. Thank you, Effie and Samantha, who are behind, Elf and Samantha, who are behind the scenes, and Rawiri, who I think has gone off to do other tasks, I would imagine. So good night, everybody, and thank you for tuning in.